talks. One of our speakers, Dr. Rajesh Prabhu, was unable to come. So thank you, ma'am. And Dr. NEENA is department head in pediatric ophthalmology, strabismus and neuro-ophthalmology in Giridhar Eye Institute with so much experience, 21 years experience. Over to you, ma'am.
Thank you, Ranjini. I'm not sure whether we have time for the second talk, but I'll try to see. So the topic given to me is mastering management of complex strabismus. I don't think we can master in 8 minutes, but I will try to give you a few pearls as to what we can do. So the basic thing is to take a detailed history, look at old pictures and surgery reports, do a meticulous ocular motility evaluation and measurements in, if possible, in 9 cardinal positions of gaze, do diagnostic tests like force duction test and force generation tests, blood test to rule out atypical conditions like thyroid ophthalmopathy, ocular myasthenia needs to be done in atypical cases. Imaging is important when you are dealing with a complex strabismus. Always be prepared for intraoperative surprises. Counsel the patient for staged surgery and keep prisms and Botox in your armamentarium to tackle the residual squint. So most of the time when you have a complex strabismus, I would probably talk about a paralytic strabismus or a restrictive strabismus, not your usual comitant strabismus. So it's an incomitant strabismus, and most of them would be having an abnormal head position. So what is driving the abnormal head position? If you can understand, then probably you can tackle that, and that will help you in correcting the cause. So identify the cause and treat the cause, and most of the time it would involve weakening the tight muscle, strengthening the weak muscle, improving ocular motility, trying to reduce diplopia in the primary gaze, and give a shot at enabling binocular vision to the patient. So I will start my cases with this 21-year-old college student who came to me with was concerned about his left face turn, and he had abnormal head posture and eye movement since birth. You can see he has a left face turn, and if you can see this animation, you can notice that he has abduction limitation, -3 abduction in the left eye with palpebral fissure changes. This is suggestive of an esotropic Duane's retraction syndrome with left face turn. So we did a force duction test, which was positive for medial rectus, and we went ahead, and he was basically concerned about the face turn. So there was no upshoot, downshoot, no globe retraction. It was just an abduction -3 with palpebral fissure changes. So we went ahead and did a medial rectus recession and a superior rectus transposition to the lateral rectus, and you can see that his abduction has improved from -4 to -2, and his face turn was much better. So this is a superior rectus transposition happening, and the standard surgery in which you transpose the superior rectus to the lateral rectus, and you can augment it with non-absorbable sutures for better effectiveness. I think I'll just fast forward the video. Yeah, so here the superior rectus is attached next to the lateral rectus, and we are kind of augmenting with non-absorbable sutures. So this was another 7-year-old boy who was ridiculed by his classmates, and he had stopped going to school because they were making fun of his abnormal head posture. Again, he's having a left esotropic Duane's retraction syndrome. So again, we did the same thing. Force duction test showed a tight medial rectus in the left eye, and so the angles were larger here. So what did we do? We did left medial rectus recession, and again superior rectus transposition to the lateral rectus. You can see the HP is well corrected after surgery, and even his abduction has improved in the left eye. So coming to a more complex Duane's retraction syndrome. So this boy presented to us again with left face turn, but the squint was visible in the normal eye. The left eye was having Duane's retraction syndrome with abduction of -3, but it was the right eye which was squinting with hypertropia and esotropia. It was more like a DVD, not a true hyper, but the right eye was unmaintained. So we were like worried whether is this an upshoot of Duane's in the other eye, or is it an updrift of the DVD? That was a confusion. But he eventually found that it was an updrift of DVD in the right eye, and he was fixing with the Duane's eye. So what to do in this patient? So again, force duction test was done. It was positive for medial rectus in the left eye, but since he was manifesting squint in the right eye, we had to do surgery in the right eye also. So what we did was we did asymmetrical medial rectus recession here, very small angle in the left eye, and a larger medial rectus recession in the right eye, and That actually improved his head position, and also we did an inferior oblique recession in the right eye to take care of the large DVD. You can see miraculously his face turn has disappeared and his DVD is well corrected, and esotropia is also well corrected. So the surgery is standard medial rectus recession, but I did asymmetrical, more in the in the unaffected Duane side than in the Duane side. So another girl with exotropic Duane's retraction syndrome of the right eye with left face turn. Now exotropic Duane's is quite rare, and here again what I did was I did a bilateral lateral rectus recession, asymmetrical, more in the better eye than in the Duane's eye, along with a Y split to take care of her upshoots and the abduction, upshoot and her exotropia. So moving on to restrictive strabismus due to thyroid ophthalmopathy, you can see this lady has a large right ezo and hypotropia. She was found to have bulky extraocular muscles, especially the tight medial rectus and inferior rectus. FDT was positive. So what we did was we did a recession of the medial rectus in the right eye along with an inferior rectus recession, and you can see she's much better cosmetically and functionally after surgery. So this was a 28-year-old painter who came to us with an head injury, post-head injury with severe diplopia and down gaze. This is how he looks, a right head tilt. So we can imagine what he's having. He's having a left superior oblique palsy with intractable diplopia, large angles. So what did we do? We did surgery in both the eyes. We did weakening of the antagonist in the left eye, that is the left inferior oblique recession, and coupled it with an inferior rectus recession in the good eye. And you can see he's much better after surgery. The head post is abolished. He became totally diplopia free, and he was able to go back to work. So a squint surgery can really help to get over diplopia if you're able to get a good measurement and find out where is the maximum deviation and do surgery accordingly. So this was a case of bilateral 6-nerve palsy, and this patient was very depressed because he was having severe diplopia. We did vertical rectus transposition to lateral rectus. This is one of my old cases. Now I do Nishida for most of them, but in this case we did vertical rectus transposition to the lateral rectus, and you can see he's much better after surgery. Of course, he had some residual esotropia for which we gave him prism glasses. Why did we do transposition in these patients? Because post-duction test was negative. It was a case of paralytic strabismus. Now coming to this 6-year-old girl who came to us again with a very large angle esotropia. She had a pontine glioma post-excision and radiotherapy. She landed up with this horrible diplopia and squint. She refused to go to school, and we had to do something for her. So this is how she was. In this case, I wanted to buy some time and I wanted to see how she's going to behave after surgery. So I gave Botox to the medial rectus. So this is one condition you can actually give Botox. You can see she became pretty good. She was so happy after Botox, but the effect lasted only for 3 months. And then we had to go ahead and do bimedial recession and a superior rectus transposition to lateral rectus in both the eyes. She's much better in the primary position. Although she still has limitation of abduction, her angles have come down a lot. So this, you can imagine what it would be. This child with chin-up posture, right upper lid ptosis, right hypertropia is a classic case of monocular elevation defect. We usually see such patients, and they have this head posture from birth. And after treating his amblyopia, we took him up for surgery. Of course, FDT was negative. So we decided to do a modified Nishida. In modified Nishida, there is no disinsertion of the muscle. We just take 1/4 of the muscle and we transpose it superiorly. Both the horizontal recta are transposed to the superolateral and superomedial compartments towards the superior rectus to give an upward pull and taking to improve the elevation. And you can see after surgery, his elevation has improved to -2 from -4, and in the primary position he became orthotropic. So that was and we of course augmented these these cases are done with non-absorbable sutures, and this is a big game changer in strabismus surgery, because these you don't have to disinsert the muscle at all. So this gentleman had a left horizontal gaze palsy with a left 6-nerve palsy. Now you can see he has a large angle esotropia. Along with that, he also has a left face turn because he has left horizontal gaze palsy with 6-nerve palsy. So in this case, I didn't know really what to do, but since he also had a 6-nerve palsy, I went ahead and did an FDT, which was negative, and we did a medial rectus recession of the left eye with superior rectus transposition to lateral rectus. He's much better after surgery, though he's not able to move his eyes to the right, but his primary position squint has improved and improving his head posture. Another lady post CP angle tumor excision, combined 6th and 7th nerve palsy, very bad diplopia and lag of thalamus. We undertook her for medial rectus recession. After FDT, confirming it to be negative, we did medial rectus recession in the left eye with superior rectus transposition to the lateral rectus and a tarsography, and she became much better. A word about nystagmus with face turn. These are complex surgeries. Patients will come to you with nystagmus with abnormal face turn. Like this boy, he had this 30-degree face turn. So this is him after Kestenbaum-Anderson's procedure. You can see he didn't have a squint, but he only had abnormal head posture due to nystagmus. So there are various modifications, Wright's modification, augmented Kestenbaum you can do. You have to individualize depending on the patient's face turn and presence of any strabismus or not. Another lady with nystagmus and a right exotropia, I only did an Anderson's procedure here because she had a left face turn. That means she's having her eyes are fixed in right gaze. So I just weakened the right eye was exotropic also. So I just weakened the right lateral rectus and tightened the right medial rectus. That took care of both the strabismus and her nystagmus. She became much better after surgery. So I'd like to end that. I think no presentation is complete when it is a complex strabismus. These are all just some pearls that you can understand, but every patient has to be individualized and the management cannot be tailor-made for all patients. Thank you.
Thank
Do
you,
we
ma'am.
have time? I think we just we don't have time. So I think Dr. Rajesh was unable to come due to an emergency. So if there are any questions, we can take questions.
I just have one question, ma'am, regarding transposition procedures. In what all cases you do Foster augmentation, or you do it routinely for all cases? Any specific
All
indication?
paralytic strabismus you need to do, but when you do for Duane's, I don't generally do a Foster's augmentation because most of the time, because sometimes these Foster's augmentation can produce torsion. And Duane's is not a true paralytic strabismus. It is you have to see the tone of the muscle. The lateral rectus is not dead there. It has abnormal tone. That's it. So you have to look at the FDT, FGT, everything. And most of the time, I get away with just a transposition. I don't do a Foster's augmentation. But for other paralytic strabismus, if the angles are large, at least if it's more than 25-30, usually I put in a Foster's augmentation suture.
Thank you, ma'am. Do you have?
Madam, so in MAD, you prefer doing modified Nishida rather than inverse snaps?
No.
Regarding
I'm going to come to that. It's my experience in small angle MADs, that is less than say 20-25, Nishida works very good in my hands. But for larger MADs more than 35, I prefer naps. Because in my hands, the Nishidas gives around 25 maximum. That's what I have seen. Though there are reports of people doing Nishida for very large angle strabismus, but Nishidas gives me maximum 20-25. So it does not give me more than that. But when you have very large angles, I do prefer to do a naps.
Till what age do you wait for doing surgery in an MAD?
So I don't jump into surgery. If there is amblyopia, please treat it. Most of them will be amblyopic. The vision should at least they should come more or less equal to the other eye, unless it is such a bad strabismus, child is not able to even bring the eye to midline to fix. Then you can do surgery. But most of the time, once the eye is straight, parents will stop patching.
Yeah.
And so that is another thing that we have to worry about. The amblyopia component should be taken care of, and you should be able to get a good measurement. If you are able to get a good measurement at 2 consecutive visits, almost stable, you can definitely go ahead with surgery.
Recently, I had a child, 1 year of age. I saw her at 1 year of age. Very prominent head posture. That was the main concern.
But that's good. In that case, the child will be fusing. If the head posture is there, you can tell the parents that that head posture is adopted to, use both the eyes together. So you can, try patching for some time and treat any refractive errors, and till you get a very good measurement. I don't do Nishidas on just guesswork. I have to get good measurements. What is your take, Dr. Sandra?
Angle. Sometimes when you put the patch also, they have to adopt a very
Yeah,
severe head
yeah.
posture. In that situation, I may decide to operate a little earlier.
Yeah.
But as you said, the forced action should be negative. That is one thing. And larger angle, definitely Foster's will give a better. Naps with Foster is the choice rather than Nishida. Nishida I usually reserve for like the older patients who like older where because it takes very less time to do the procedure. So otherwise usually go with Foster's naps.
So that's an end for an IC. I would like to thank.
Take a picture together.
Yeah, I
A
would
quick
like to
picture.
thank all the speakers, Namita, Sandra ma'am, and NEENA ma'am for coming and speaking on this IC. Thank you so much.